that your interest is still very much alive, and I'm grateful for that. So when we talk of respiratory medicine and palliative care, there is one thing that I really need to start with. The point is, you must have all heard that palliative care historically started for the treatment of patients with cancer, and not just cancer, patients who are dying of cancer. Hence, unfortunately, palliative care is often misunderstood even today to be something meant for cancer patients only and for those patients at end of life, both of which is not true. And one of the slides that actually helps us understand this better is today, if you see the number of chronic conditions that is suffered in India, a lot of these chronic conditions are lifestyle diseases. So for example, blood sugar, blood pressure, dyslipidemia, smoking related COPD, tuberculosis, interstitial lung disease, cardiac events, cerebrovascular events. So all these are chronic conditions which actually affect a large number of Indians. Yes, we do add cancer patients, about 1 million cancer patients every year, but that is nothing compared to the number of Indians who are already suffering these chronic illnesses. And as doctors, you will all appreciate the fact that we are able to cure only 1/3 of the conditions, correct? So if you all put your head together, can you in the chat box send me those conditions in the respiratory disease that you're able to completely cure? There are 1/3 conditions which we are able to control, like asthma. There are 1/3 conditions which is incurable or uncontrollable, like probably interstitial lung disease, advanced COPD, as well as certain forms of lung cancer. So which are the conditions in respiratory medicine that we are able to completely cure? And if you think of all other systems, neurology, gastroenterology, cardiology, we are able to cure only 1/3 of our patients. The rest of the 2/3, we are hand-holding them, we are counseling them, we are only able to control, or it's incurable. Therefore, bulk of the conditions that we see needs palliative care. What is the meaning of hand-holding? It is just trying to control emotions, physical symptoms, sugar levels, blood pressure levels. So you must remember, as a doctor, every doctor needs to be trained in palliative care, and you need to wear your palliative care hat appropriately, because every condition is not cured by us. Okay. In respiratory medicine, this graph is just to show you that all common conditions, be it COPD, be it TB, and be it asthma, be it interstitial lung disease, the incidence of these situations are on the rise. In India, it's complicated by domestic air pollution also. So please remember that the global burden of respiratory conditions, India shares 1/3 of the global burden of respiratory conditions. So the world's 1/3 of the illness is in this country. Also, now we are the most populous country of this world. So combined with the fact that so much of, because of the fact of domestic pollution, cigarette smoking, late diagnosis in tuberculosis, poor diagnosis, poor adherence to treatment, we have a lot of burden of chronic respiratory conditions. Now, all of you by now must also be familiar by this graph. Am I right? You must have seen this graph before. And this is just to highlight graph C. And when I mean by saying graph C, that is exactly where our patients with chronic illnesses and chronic organ failures fall in. So if you see this graph, these patients of so-called non-cancer chronic conditions, or you could say non-communicable diseases, or focus on COPD and ILD. These patients get diagnosed fairly early. COPD gets diagnosed at the age of 60 or 65. These patients then lead a very prolonged period of life with a high symptom burden, say 10, 15 years. And every time he visits the hospital, it's only for an emergency. So pulmonologist or intensivist see this patient in an emergency. And every time he goes home, you will realize that his quality of life is nowhere compared to what it was at the time of diagnosis. So this man is slowly fading, slowly worsening, and it is probably going unnoticed because the pace is spread over 10 to 15 years. Typically, hospital consultants see these patients only in acute exacerbations. So when these patients go home, we don't even know whether these patients are self-caring, they're able to walk to the toilet, are they able to eat on their own, are they able to talk full sentences, are they taking medications correctly, inhalers, nebulizers. So many things are happening when a patient goes home discharged from the hospital. So unfortunately, non-communicable diseases or non-cancer conditions are not perceived as life-threatening. What do I mean by this? Is that if you diagnose a patient to have lung cancer, the next question in his mind is, how long do I have to live? But if you diagnose a patient to have COPD or interstitial lung disease, that is not the next question he asks, because he is not explained about the fact that this condition is incurable and that this condition is progressive. He feels the doctor is giving him treatment and he will get better. And there is no other worry at all. So we also as doctors need to realize that it is our onus as respiratory physicians to be forced to be able to foresee and foretell, to describe the trajectory of patients' illnesses so they are better prepared and they're also better, they know what to expect from their condition. Okay, so it's very important to remember that non-cancer conditions get fewer referrals to palliative care. They're not perceived as life-limiting. They lead a very long period of time with a very high symptom burden. Any questions or doubts? So if you think of any chronic lung disease or any chronic illness for that matter, it is like falling off a skyscraper. So please remember, as the patient is worsening, I was telling you, it is our onus as doctors, because we have seen more than 100 COPDs, no more than 100 interstitial lung disease. It is our onus to educate patients with timely, unhurried, sensitive conversations. We should not wait for the patient to reach such a stage that now we say that we cannot do anything. Very often we hear that, or we also hear residents saying that if we don't admit in ICU and we don't put on the ventilator, your patient will die. This is not the way to communicate. This patient has been deteriorating for a long time, and yet we haven't taken the responsibility to warn them. Because the manner in which you land depends on the way you fall. And if this fall is punctuated with good conversations, with expecting the patients, explaining to the patients and family what to expect, clearly they are better prepared. But it has to be done in a very sensitive way, in a language they understand. So that is where we come in as respiratory palliative care physicians, where we would like to integrate this palliative care when we can offer some treatments to the patient and gradually work as a team. As the patient's condition worsens, the palliative care options become more and the curative options fade away. It is important because the patient doesn't feel abandoned. Very often now it happens so that the pulmonologist treats the patient till really nothing can be done. The pulmonologist is so frustrated, saying, now you go and meet this lady. The patient feels this doctor of mine for the past 5 years or 10 years is now suddenly sending me to somebody else. Why should I go to that person? So it has to be shared care. It has to be a smooth transition so that these patients also feel cared for and their treatments are not abruptly ended and started. And the beauty of palliative care is that we not only look after the patients and their caregivers during the treatment, but at the time of actively dying or at end of life, and also bereavement. Imagine looking after a patient for 10 to 15 years, and on the death of that patient, it is a big void for the caregivers. It's been difficult journey for the caregivers too, and we are not able to, we should be acknowledging their hard work also. Okay. The most important thing that pulmonologists ask is, if I refer to palliative care very early, that means the patient feels I am giving up or loses hope. And if almost always the referral is so late that there is no time for me to form a rapport with the patient, to explain what I can do to make the quality of life of that patient better. So the timing of the referral is very, very important. And it's a very much researched question in England. So if you are sitting in your outpatient clinic and you have a patient of advanced COPD, or you have a patient of advanced chronic respiratory condition, you think in your mind, he's on oxygen, he's barely able to complete a sentence, he's barely able to move, he's got multiple hospital admissions, he's got multiple comorbidities. You, with your clinical acumen and clinical experience, will be able to tell whether this patient will be alive to see the next Christmas or next Diwali. If in your mind the answer to that question is no, that is the time for proactive palliative care. It's a very simple thing. In your mind, you think this is an elderly person, so many comorbidities, multiple admissions, one admission to the ICU, 24-hour oxygen, so many medications, still so breathless. And then you think this is the time for this patient. He might not see the next year. It is time for proactive. This gives you enough time for the patient to get to know you, your relatives to get to know you, discussing all the issues, the problems, the logistics, whom to contact in an emergency, what to do in an emergency, where to come, where not to come, to get admitted in ICU or not, to be ventilated or not. All these discussions, all these points can be discussed. Any thoughts or anything you all want to share at this point, or shall I continue? Okay. So again, there are two documents which I would request all of you to read, both of which Pallium India can share it with you. One is the gold standard framework, and second is the blue maple document, which is made in Manipal. Both documents actually list out indicators for palliative care referral in every chronic condition. So right from CKD, dementia, Parkinson's, motor neuron, chronic respiratory diseases, chronic renal and chronic liver. So everything is listed. So if your patient, I have picked up the criteria for referral for COPD. If your patient satisfies any two of these following criteria, which is number of hospital admissions, when the breathlessness grade is MRC 4 to 5, when the patient is worsening pulmonary function test, continuous oxygen, maybe using NIV, ICU admissions, severe comorbidity. It's not even that the patient has to satisfy all these criteria. Any two is enough to start the referral, because the prognosis of this patient is poor, and it's important to realize that this person will deteriorate. So it is important to understand to go. I request Pallium to please send you those two documents, because then it becomes easy for you to refer patients and integrate palliative care at an earlier stage. So these are the two documents which Pallium India will share. Another interesting highlight to show you here is that despite the West, the amount of integration of palliative care is fairly good in the mainstream. Still, a study showed that 80% of cancer patients got palliative care, and only less than 2% of patients with COPD or advanced chronic lung got palliative care. So it's long time to go. Another sad thing is those patients with advanced chronic lung disease who got admitted in the ICU, they were the ones who, despite no curative treatment, were subjected to more aggressive invasive treatment. Their distressing symptoms were less documented. Therefore, their distressing symptoms were less treated, and they basically died a poor quality death along with more CPR. So there was no dignity in the quality of death. It is important to realize that cancer patients get at least more referrals to palliative care, while COPD and interstitial lung disease don't. And the sad part is that even the fact of unnecessary invasive treatment, ICU, intubation, dialysis, CPR are subjected to more because it's available. The point is, we need to think of the medical ethics. Is this what the patient wanted? Is this in the best interest of our patient? Are we doing harm to our patient? And therefore, is there justice? So just because a person can afford treatment doesn't mean he gets subjected to A, B, C, D, because it's available in an urban metro of India. The other thing which we never realize is when we send patients home from the ICU, we feel, yes, he survived, he's gone home. So we equate quality of life to survival. But please remember, the focus should be on quality of life and not quantity of life. Because in a follow-up study of patients who were admitted with COPD, 25% of patients were only alive and well with decent quality of life. Almost 50 were readmitted and the 25 were dead on going home. So the fact that the patient survived your shift doesn't mean he's going to survive life with a good quality of life. And once you leave ICU, even during COVID times, you must have seen that patients go through a lot of stress, which is equivalent to a post-traumatic stress disorder, of how he survived the ICU, the nights in the ICU, the beeping machines, of how his arms and legs are bruised. So it's not just the physical trauma, but it's the total pain, financial, social, emotional, that the patient goes through. We must select patients well before we put in ICU. And just because we have an ICU and just because the corporate hospitals have a different way of functioning shouldn't be the reason to keep admitting patients in the ICU. So there you go. The mortality after admitting these patients is also fairly high. So coming to the main symptom like Radha described. So till now, I was trying to emphasize on the need for palliative care in respiratory medicine. It is nothing not different on how our patients suffer during the journey of their illness and even at the time of death. Now, all of you know this, that when you have a patient of breathlessness, you will do a detailed history, you will do all these investigations. Now, the two investigations that is important that you need to do is arterial blood gas, because X-ray, ECG, 2D echo, everybody does. Bloods, everybody do. Arterial blood gas is important. It reflects the health of the lung with the respect to the pH, the carbon dioxide and the oxygen, and the pulmonary function test. Very, very important to tell you whether it's obstructive, whether it's restrictive, what is the situation of the diffusion capacity. So it gives you a lot, and it is not a very well utilized and very well performed test. About pulmonary function test, details is actually an entire class on its own. But if you all are interested, we will definitely let you know. Now, in our history taking, when you're asked about patients with breathlessness, we often stop with, is your breathlessness better? Are you taking the inhalers? What makes you breathless? What relieves your breathlessness? But just imagine a patient who is breathless every single minute, 24 hours a day, day after day, week after week, and year after year. So for this, I'll request you to do a small exercise with me. So if you all can sit straight on your chair, okay? Take a deep breath in and blow only half out. So take a deep breath in, blow half, and take a deep breath in and blow half. Do this for the next 10, 12 seconds and see how you feel at the end of that breath. You want to breathe out with an exact. This is how our patients feel all the time when they are not able to take a deep breath. So imagine feeling like this every single moment of your life. The issues with breathlessness is something we never ask our patients. For example, the frustration, the dependence, the anger, the inability to do things on your own, the fact that at one point you were running the house and now you're nobody and nobody asks you for anything. So we need to train ourselves as palliative care physicians to ask these questions. Are you coping? Our history taking has to change, and it has to say, what have you given up because of your breathlessness? What is it that you have stopped doing because of your breathlessness? And that is when the answers will come. I can't even go to the toilet on my own. I can't take a bath. I can't change clothes. I can't go and play with my granddaughter. I can't go gardening. I can't do my shopping. So many things will come. We only ask closed questions. Are you breathless? Are you better? And that's when our consultation ends. If you change the way you ask questions, it is going to make a big difference. And that is when all the patient complaints come. I can't do this. I'm dependent. I'm a burden on my family. And that's when you realize that breathlessness is not just a physical symptom. When a person is breathless due to any chronic advanced condition, it can really affect him psychosocially, emotionally, and many often it has been described that patients of respiratory conditions die a social death before a physical one. Their isolated in their houses, they are bed bound, they are house bound, like how we were in COVID, and it can be really distressing for our patients, right? So our patients, therefore, to describe it even better, are actually stuck in this breathing, thinking, functioning vicious cycle. Because of the underlying pathophysiology, patient is breathless, there's an increased work of breathing, and their respiratory rate is high, and they're constantly huffing and puffing. When your respiratory rate increases, you automatically become anxious. The thought, the fear of death, oh God, what is happening to me? So, and the only thing that is working over time is your mind. So you have a breathless patient who in turn feeds into the anxiety. Now, with those two in combination, the patient is so petrified to move that he keeps sitting in the place. And what happens when patients sit in one place? They lose muscle mass, because if you don't use the muscles, you lose the muscle. So our patients now become deconditioned. So the biceps, the quadriceps, the hamstring, everything becomes useless and weak. So now if the patient is even attempting to do something on his own, he's so breathless that he gets stuck in this vicious cycle. Breathless because of underlying condition, worsened with the fear, anxiety of the mind, and also the deconditioning because he doesn't move at all. The beauty of integrating palliative care here is that the pulmonologist looks after the breathing, the physiotherapist looks after the deconditioning and slowly builds up the exercise, stamina and endurance, relaxation techniques, and the psychologist deals with what is happening. So it's a beautiful multidisciplinary team which helps the patient and the caregivers, because sometimes patients feel very intimidated to ask you and me questions. They're happier talking to paramedical staff. They're happier talking to nurses. So palliative care is a beautiful mix of all these people so that there's a safety net and our patients can ask the most smallest of questions so that their issues are addressed. And therefore, if proper medication is given for the breathing, counseling for the mind, and also exercises, simple graded exercise, it will also help the patient do his activities of daily living with less effort. So, for example, if you and me want to train for a marathon, we start training 1 kilometer, 2 kilometer, 3 kilometer, and eventually are able to run 21 kilometers. Similarly, if we train our patients with in patients who are chronically breathless, they are able to do things like going to the toilet, taking a bath, or talking on the phone full sentences, eating with family. For them, these issues are marathon. We need to therefore focus on their quality of life. Let them be able to do small activities which give them joy with less effort. And that should be our aim. And that is the ethos of palliative care. So that brings me to the definition of chronic breathlessness syndrome. Our patients who have chronic advanced lung disease have this condition, which is coined as chronic breathlessness, which is patients who remain breathlessness despite maximum medical treatment for their condition. And when this breathlessness affects them psychosocially, emotionally, that is chronic breathlessness syndrome. So not all patients will fit into chronic breathlessness. You need to evaluate the pulmonologist, the cardiologist, oncologist, need to start asking, and you see that the patient is breathless at rest or at minimum exertion despite maximum medical treatment, that is the time you label the patient chronic breathlessness. And how does this help? Because we can then help the patient both with non-pharmacological and pharmacological interventions. So simple things like positioning of the patient, loose clothes, stand near a window, blowing a battery operated fan on the face. Just a 30 rupee battery operated fan decreases the sensation of breathlessness. And today, if you Google search battery operated fan plus chronic breathlessness, there are research articles of how easily caregivers cannot panic and help their patients before rushing to get to the ambulance and go admitting in the emergency room. Secondly, when suppose patients enjoy cooking or patients enjoy gardening, they should have somebody to supervise them and somebody to help them plan, prioritize, and pace their activities. So, for example, somebody can help them with keeping the kadai, getting the oil, the spices, the cut vegetables, so that the person concerned can sit and do that, make that preparation so that he or she also gets the joy that I'm able to do this cooking. I cook this vegetable for my family, or I cook this dal. So let them still have the power and let them be able to choose what they are able to do and not able to do. So non-pharmacological. Okay. Parvati is saying about the International Delphi. So you know how the Delphi process is, right, Parvati? When you have a group of expert people who give you the opinion of what it should be, and that becomes the process in which the definition is formed. So it was an International Delphi which coined the word of chronic breathlessness. It's a process, a statistical process of making this. Of the breathlessness means if you have a patient, irrespective whether it's 1 hour, 1 week, 1 month, 1 year, in this situation of being breathless despite medical treatment in affecting his psychosocial health, that patient has chronic breathlessness. You understand? Okay. See, when we say chronic, for example, when we in MBBS, when we were taught chronic, anything more than 3 months. Correct? Acute is when the patient had and didn't have. So in chronic breathlessness, this is a condition which the patient is actually having that illness for a long time. And despite maximum medical treatment, irrespective of whether the patient is breathless for 1 day, 1 hour, 1 week, 1 month, it is chronic breathlessness. You understand?
Okay, thank you, ma'am.
Yeah. Okay. So non-pharmacology comes in a long way. The physiotherapist can actually teach the patient some relaxation techniques. The relatives can do some massage, some music, some pet therapy, and all, like I told you, the handheld battery-operated fan. Please do this homework and please share amongst yourself the beautiful articles which actually say that the 30 rupees or 60 rupees operated fan can actually prevent a lot of casualty visits and a lot of unnecessary ICU admissions. Okay. And then after that is the pharmacology. Now you all know how to treat breathlessness, whether it's diuretics, bronchodilators, steroids, nebulizers, all of that you know. Point here that we need to talk about is oxygen. Very, very important. And we saw what happened in the wave 2 of COVID by using oxygen unnecessarily. Oxygen is also a drug. Yes, it is a very important drug for the body to function, but unnecessary oxygen also can damage the lung with a nascent free radical. So when your oxygen saturation is above 88, do not give the patient oxygen even if he is breathless. Because the cause for breathlessness could be anxiety, could be pain, could be some bad news, could be fear, could be anything. So first, try non-pharmacological. Even after that, check if the oxygen saturation is not below 88, do not give oxygen. Because in certain patients, like COPD patients, yanking up oxygen can also be dangerous because carbon dioxide also starts building up. And this patient, you will see, suddenly starts becoming more and more drowsy. So please discuss with the pulmonologist, what are the indications for oxygen? When should you increase the oxygen? And you must try non-pharmacological when these patients get acutely breathless. The second and the most important thing, which is important as a palliative care physician, is low dose opioids. Yes, very often pulmonologists also fall off their chairs when we talk about morphine. Morphine is a centrally acting drug. Morphine in pain is very different action. In breathlessness, we give a very, very tiny dose. We start with 2.5 milligrams twice a day and gradually review the patient and increase the medications. So the advantage of morphine, because it acts on the central, it decreases the respiratory rate. And we give such a small dose that it doesn't knock off the patient. It just makes him less breathless. And how? It decreases the sensation of breathlessness. It doesn't bronchodilate. It doesn't remove the fluid from the alveoli. It's not a phosphodiesterase inhibitor. It just reduces the signals from the respiratory center. It reduces the work of breathing. So patients start having better tidal volumes, better depth of respiration, and less anxious, and therefore they're more calmer. And I have patients who come on the wheelchair for the first consultation, and subsequently they actually have time to dress up and walk from the car park or from the bus stop to the clinic on their own. So you actually are making a difference by improving their quality of life. So they say simple things like, I could now manage to go to the toilet on my own, or I can eat, without stopping and coughing. I eat with my family at the dining table and not in my room. In these 5 to 6 years, I haven't seen any situation where morphine causes respiratory depression and death. We do not give more than 30 milligrams of morphine in 24 hours for breathlessness. And to be honest, I have never crossed 20 either. Abroad, most of the literature says of sustained release morphine, but I use immediate release, and I have gone maximum up to 20 milligrams of morphine. Patients actually have 80% of the patient have given the feedback about how their quality of life has improved. I've had patients in a survey done who live for 8 to 9 months after initiation of morphine, and they die peacefully because in that time we have had enough discussions about how they would like to be treated at end of life, where they would like to be treated, and by whom. So all these discussions are done. It is hard. It is not easy to have these discussions, but it's better to have it than not at all, and better to do it when the sea is calm rather than in a storm. So please remember, it's a wonder drug. It has a great statistical significance on how the patient feels, and there is no instance of high carb. So even if the patient has type 2 respiratory failure, you can use morphine along with NIV if the patient is happy to use the NIV. Okay. Then morphine is also very useful in terminal breathlessness. That is not just in respiratory, but it could be congestive cardiac failure, it could be CKD, it could be terminal oncology patients where we aggressively control the symptoms by infusion of morphine and midazolam and see to it that the patient transitions in peace. This has to be done by strict identification of which patient to be selected, talk to the patient, talk to the family, document it, have the GP or the in the hospital on board, and we give it through a subcutaneous syringe pump at a very, very slow dose of 10 milligrams of morphine and 5 milligrams of midazolam over 24 hours. And usually the patient is, started within the last 2-3 days of life, so that the patient is not struggling and the family also doesn't have to watch the patient struggle. The patient is in sedation and transitions in peace. So please remember, terminal breathlessness, again, very often important because the manner in which a loved one dies is etched in the memory of those who live on. So for the sake of the fact that our caregivers shouldn't, live with this burden and that our patient doesn't suffer, you must aggressively think of discussing terminal breathlessness also with your patients, which we do quite commonly. So please remember, it is a thing which is done for comfort. Yes, the side effect is death, but it is given in patients who are imminently dying or actively dying. It is medico-legally allowed because it is in the best interest of the patient with the consent of the patient or the family. And it is important to have clear communication and documentation. So please remember, this is not unethical. This is not euthanasia. You're not giving a whopping dose of a medication to end life. You are giving small doses of medication to comfort the person till he dies. So there's a big, big difference. And I'm happy to take questions if there are any. Okay, so just going through other symptoms, cough, which is a protective reflex, but when it's persistent, it can be very, very distressing. Again, we focus, must not be just respiratory because it could be cardiac, ENT, upper respiratory, drugs, treatment, psychogenic. So explore your history properly. Next, any persistent cough in an underlying chronic advanced lung disease, you must think of non-pharmacological first, like I told you. So, lifestyle habits, eat early light dinner, 3-hour gap, small frequent meals, those kind of things, hot water. And then pharmacologically, what we try and do is first the codeine, then introduce the morphine. And then now there has been results of drugs like gabapentin, which has been useful in patients with chronic, distressing, intractable cough. So we start with 100 milligrams in the night and then slowly increase to 300 to 600 because one of the side effects of this medication is drowsiness. Patients report well. How to step up dose of morphine. Yes. So Deepa, what we do is we start with 2.5 milligrams 12 hourly with laxative because morphine at any dose causes constipation and a patient with chronic breathlessness cannot afford to be constipated. So once the patient benefits from it or reports being a little bit better, we make it 8 hourly, then 6 hourly, and then 4 hourly. And each of the times we tell them he can take an extra dose. So before a bath, he can take the 2.5, or before he's going to do an activity like physiotherapy, etc., he can take a 2.5 as an SOS if he's needed. And strictly, we do not go more than 30. And I have never needed more than 20 to 25 milligrams of morphine. We are happy to share articles if you all are interested of chronic breathlessness with morphine. Low dose opioids are extremely safe and it has to be done responsibly. You need to keep a list of patients you have given the low dose opioids and keep in touch with them if they do not report back to you. Okay. Similarly, like I said, so codeine, then morphine, then gabapentin for chronic cough. Okay. Then pleural effusion, again, a very common thing seen by pulmonologists where repeated filling is very distressing for the patient. Most common cause is cancer, and we therefore need to treat with respect to the prognosis of the patient. So if the prognosis of the patient is good, we can put an indwelling pigtail catheter. Sorry. If the prognosis is poor, then we advise one-time aspiration and then control of symptoms like with morphine. So please remember, again, assessment, history taking, and what the patient understands and wants is very, very important before you dish out a prescription. So this is what I said, depends on the prognosis of the patient. Hemoptysis, again, scary. Some patients, we should be preparing them that this might happen. So they need to keep dark towels. Sometimes in hemoptysis, the fear is dying of aspiration of the blood and not necessarily loss of blood. And therefore, when these communications are important, patients need to have contact numbers of tertiary level hospitals where complicated procedures like bronchial artery embolization, laser ablation, cryosurgery, brachytherapy can be done. So these things need to go with the discharge of the patient if you're anticipating hemoptysis. Okay. So very important. And we can do rigid bronchoscopy. We use adrenaline. We can use tranexamic acid. We also give the patient tranexamic acid orally and injected to stop the bleeding. A small note on pandemic and palliative care. I strongly think if most of our doctors were trained in palliative care, we would have handled the pandemic better. It was tough, not just for the doctors, but for the entire population, medicos, non-medicos, patients, non-patients, rich, poor, elderly, young, everybody. So ideally, the way we could have done it better is been better support with each other, triaged patients better, given the right patient, the right kind of treatment. So there was no chaos about bed availability, run from hospital to hospital, and also the grief and the bereavement that followed, because there are families who lost more than one. There were families who couldn't see their deads. So there's so much in the pandemic that we could have actually dealt with better. With that, I stop the presentation on the fact that how in respiratory care we can actually integrate palliative care and improve the disease experience, not just for our patients, not just for our caregivers, also for us doctors. So if you have proper transparent communication, documentation, it is a win-win for all of us and less stress for all of us. And we will be able to practice medicine in a much more ethical and unstressful manner.